All right, can folks see that? Josh, can you see it?
Yep.
All right, great. So, we talked about different approaches to the pineal gland yesterday. And to be honest with you, the more common approach is the supracerebellar approach. And that's the one where you come really from the midline in the back of the head, or lately we've been doing it off midline and go over the cerebellum. But I've got an old video of a supracerebellar approach. An occipital transtentorial approach. And that's more of an approach through the top of the head here, between the occipital lobe and the falx. And so what you see here is this is the falx actually. And this is the occipital lobe being retracted. And this is a suction and a small scissor. And we've actually made a cut in the falx, in the tentorium, going towards what's called the incisura, where the tentorium kind of separates around the brainstem. And you have to be careful here because there's something called the straight sinus, which is a big venous structure that the vena galen drains into as it goes towards your posterior kind of venous drainage. And so I'm just going to let this play because it's kind of slow. This is a case I did towards the end of residency, actually. And so you can see this is the cut in the falx here. All right. And again, because of bleeding concerns, you want to make sure that you absolutely cauterize this very, very carefully. There can also be little venous lakes in this region. And venous lakes are exactly what they sound like. They're pools of venous blood, because what's important to understand is that venous anatomy, the sinus anatomy, they're veins, but they're not proper veins. They're actually just folds in the dura. So the dura has two layers and they open up and venous blood flows through that. And then when it gets to the internal jugular, some of the other venous drainage, that's when it becomes proper veins. That's another cautery tool that just came in. It's called an aquamantis. It's a small aquamantis, and it's a stronger bipolar tool, so it's more precise. We're just cauterizing there. And you can see here kind of elevating to make sure that we're not hitting any of the structures. Directly underneath us here is the cerebellum. The midbrain would be over here more. So I'll move this along so we can get to spine. I know that's why you're all here. I can't see the chat right now too. I'm sure there's tons of questions coming in. So anyway, just you make small cuts basically, and you open this up pretty wide. And the goal here is to actually, you can retract the tentorium so that you can see the cerebellum, the quadrigeminal cistern, which is the CSF space behind the midbrain and in front of the cerebellum. Move it a little further along. So again, just kind of open this delicately, obviously done under a microscope. And this is just cauterize and cut, cauterize and cut. And then about right here, probably the last cut. And you can see here now, we'll take out this cottonoid. This is just a cotton patty that we use in surgery to protect important things and also, obtain hemostasis. It's absorbent, it's compressive. Wash it out a little bit. And you can start seeing, this is arachnoid. We always talk about the arachnoid. It looks like spider web kind of billowing out. And it's actually a contained space. So there's CSF, outside of it and then inside of it. And so here we're going to start retracting the tentorium laterally to give us a really broad exposure of the cerebellum. So we're looking infratentorially from a supratentorial approach. And you can kind of tuck it back here. And so through this thin layer, you see a blood vessel there. This is cerebellum here. The quadrigeminal plate will be over here. All right, and this is the quadrigeminal cistern. And so once we tuck that out of the way, the next step is to open up that cistern. And you can see we're controlling the focus and the zoom on the microscope actually with our feet while we do this. So this is a tiny knife, call it a beaver blade or an arachnoid knife. And we're going to cut through the arachnoid. You got to remember, this is probably a 7 French suction. So it's a 7 millimeter diameter. So this whole space, right, is probably, it's probably 3 centimeters, which if you think about it, 2.5 centimeters in an inch, right? So it's another small tool called a Roten microdissector. We use that to kind of bluntly pull the arachnoid apart. And you can see CSF starting to come out of there. For these cases, I don't know if Deepak mentioned it yesterday, we typically insert a spinal drain for coming from above. And that's because you really don't want to retract on the brain. You can see there's no retractor here at all. This is actually dynamic retraction. And so by draining CSF, the brain softens and there's more space to manipulate it. And so you can just kind of pull gently on it. And by moving your suction around a lot, you never get consistent pressure in one place. And that's super important because retractors, if you retract too hard in the brain, the brain vessels are extremely delicate and you compress them. And so you can actually get infarcts in that tissue. You can get strokes in the tissue just from excessive retraction. That'll get more in focus in a second. So you can see again, that blood vessel under the arachnoid, a bigger vessel here, cerebellum. And you can see the arachnoid, it's not just that outer layer, there's little adhesions throughout. And so the next step is basically going through there and cutting all these. For the most part, you can pull them apart. And again, so this is probably a 3 millimeter tip on this instrument. So these are vessels that are, 3 millimeters or less in diameter. Extremely delicate. And then you can sharply cut some of these. The trick for arachnoid, and it's a vascular neurosurgery trick, is you create some air underneath it so you can see what's under it, and then you can cut it. And you want to make sure you're not going to cut the vessel, obviously. So these thin connections can all be sectioned. And you see it's actually, a decent sized space here. The tumor in this case was a low-grade glioma of the inferior colliculus, which is an extremely strange place to get a tumor and an extremely difficult place to reach. And so with the occipital transtentorial approach, I don't know if Deepak went into reasons to use that versus other ones. It gives you a very direct shot down into there. And I think I've said before in my lectures that surgeons can only really see in straight lines. So you want to always have as much of a straight line to your tumor or your lesion as possible. So we've advanced forward a little bit. This is a tumor forceps, and that's actually pushing some of the vessels away, dissecting them. Extremely gentle touch here. You can see these little perforators. These are, 1 millimeter or less in diameter. And we're starting to see, this is the brain stem from the back. You can see the little vessels attached to it and how delicate they are, right? That one just starts bleeding just from manipulation. And then the tumor is actually right here. It's this kind of blanched white area that's a little bit thickened. And so, you need navigation in these cases. Ultrasound really can't help you because of how far away you are. If this was a high-grade lesion, we would use fluorescence. But basically, the procedure went on to involve resection of that lesion. So let me take a few quick questions before I show you the next thing. All right, what do we got? Did you use an exoscope? So no, that was actually from residency. We did not have an exoscope. Exoscope is something new I use here. I think an exoscope would be great for this case, actually. It's it offers a great field of view, and obviously the comfort of sitting there and looking straight ahead with the 3D glasses. So be very useful. Burr holes placed in this one. So you want to actually do something called slot the sinus, or you want to remove the bone over the sinus. And so that's, the superior sagittal sinus is right in the middle, and you want to take the bone off completely, unroof it, because you want to be able to pull your dura over more. You want to maximize how much dural exposure you get. And you can actually put a retractor on the falx without the same risk that when you put a retractor on the brain. We don't ligate the sinuses here. We actually, even the tentorial cut, we want to be lateral to that straight sinus. And you can actually use a Doppler ultrasound to find venous flow if you needed to, if it was particularly big. Creepily cool, but I feel so bad for the patient. That is something that I was thinking about yesterday while I was putting this talk together. I love pineal surgery. I think pineal surgery is incredible. You operate on the center of the human brain from one of these various approaches. But in order to do that surgery, someone has to have a tumor, and the risk of complications is not low. It's not high. We're able to do these successfully now, but it's a real issue. So we talk about these things. Obviously, we're very passionate about it, but you have to be careful about how you talk about these things. There's a human being that we're operating on, and bad things do happen, but for the most part, we've become very capable of doing surgery safely, and obviously, we're trying to promote how we do that and why we do it. So it's a great question. How do you position the microscope? So for an OTT, an occipital transtentorial microscope positioning is very straightforward. It's actually, you're sitting with it right in front of you. The supracerebellar approach is a little bit different. And I had some pictures, I think, in the talk that Deepak presented, where we actually have to flip the viewer upside down, and you put the scope in front of you, and you actually operate with your hands essentially like this, up in the air. And so the positioning is critical for the entire case. Your hands are outreached in front of you, and you have to use long instruments because it's a pretty deep reach, actually. Do you practice on dummies? No, we leave those people alone. What symptom did the patient present with? So just like yesterday, we talked about, people typically present with hydrocephalus first. That's how they find these issues. Otherwise, upgaze palsy is due to compression on the collicular plate. Do you sew the arachnoid back? We do not. Some people have argued for that, and it's kind of a futile task, I feel like. It's extremely delicate. You see that just with gentle pressure, it kind of peels apart. So you just let it be. CSF will flow through there. It creates communication. Nothing bad happens about it. Where did the residents make the initial cut on the body? Well, the resident was me, and it's right around here, actually. It's right on the back of the head. Does the arachnoid heal itself? No, but there's enough scarring in there that it's not really an issue. Your arms do get tired. Posterior inner hemispheric for these. So the inner hemispheric transcallosal approach has its role, especially for splenial lesions. In general, people have gotten away from this because the supracerebellar infratentorial approach goes through no brain whatsoever. Occipital transtentorial approach goes through no brain whatsoever. The biggest risk with the occipital transtentorial is that there are all the major veins back there. So your internal cerebrals, your basal vein of Rosenthal, your vena Galen are all in front of the pineal gland when you come that way. So that makes it a little bit difficult. The other thing is retraction on the occipital lobe. Some people end up with a transient hemianopsia, meaning they can't see in one field of view for usually a short period of time. It does recover, but it's just from pulling on the occipital lobe. How do you know you're only removing tumor tissue? Well, that's the problem with gliomas. So with easier tumors, there's a nice plane around it, usually a gliotic plane. With gliomas, they're infiltrative, so you have to use your navigation. You have to look for subtle tactile cues. Tumors do feel different than regular brain, and so that's important. Total time duration of the procedure. This procedure was probably about 3 hours, 2 to 3 hours. The approach on these is actually the hardest part. For some of the big pineal tumors, it can be a lot longer though. I've been involved in very long ones. How would you, someone just asked something. Pituitary gland, you go to the sphenoid sinus. Yes, a lot of times you do endoscopic endonasal for that now, so through the nose, but you can go transcranially also. Trivial bleed. Someone said one of the vessels began bleeding. Small little perforators like that you have to be careful for, but it was right on the tumor, and so you don't worry too much about that. Do you use skull-based techniques? These are all skull-based techniques. If pineal gland falls into the skull-based category, even though it's really not. What did you do with the vessel that started bleeding? Actually, just pressure. We have some stuff called gel foam and flow seal. So gel foam is a thrombin-soaked patty, basically, a little gel. And thrombin promotes coagulation. So you just push it and some pressure. Those little vessels they'll spontaneously clamp down. They'll go into spasm and they'll stop bleeding on their own. Just let them be. Cauterization in a delicate situation is actually never the answer. If the CSF is cloudy, you probably shouldn't be doing a tumor resection there. It's usually something else. You're right with what you said. So actually the sitting position, rather than the anesthesia of choice, the important thing about a seated position has to do with something called air emboli. I don't know if Deepak talked about this yesterday. So whenever your head is above the heart, your heart creates a negative pressure in the veins, right? As it beats, it pushes blood out and it sucks blood in. And so if you open into a vein, the vein can actually suck air in. And the nice thing about the seated position is that you get less bleeding in general because of this. And so the blood doesn't pool, it runs down. The cerebellum naturally falls away from you. So it opens up this cleavage plane to the tumor. But what happens is if it sucks air, that air can go to the heart and it can cause issues with retained CO2, and you can get an air emboli that can be very deadly to the patient. And so when that happens, you actually have to wax all the bony edges. You have to flood the field with irrigation. You have to find the source. And in the old days, we used to put central lines in with the thought that you could potentially suck out the air bubble. So why are patients kept awake? Patients are kept awake when we're worried about the region the tumors are in. This would not be a case where you would ever do that. But when things are close to language areas or places that control motor function, so people who need to move their hand after surgery, even though we've got a lot of advances in neuromonitoring, the most sensitive and specific way to monitor someone's function is to have them awake and using that function. You absolutely can anesthetize the patient and put them in a seated position. Postoperative complications. So the big thing with these, and I actually wrote an entire book chapter on complications of these approaches. Aside from air emboli, the big complication is obviously hydrocephalus, persistent hydrocephalus. So we tend to treat that first. And then the other thing is a venous infarct. So with this approach that I just showed you, you don't have to take many veins. But when you do the supracerebellar approach, you sometimes have to sacrifice veins. And that can lead to a venous infarct in the cerebellum, which then swells, compresses the midbrain, causes worsened hydrocephalus as well as midbrain compression. And people can get into a lot of trouble. So I'm going to pause here. I want to move on to spine stuff because I know that's what we're supposed to be talking about. The head holder thing is called a Mayfield. And basically you can think about it, if you want to operate on things that are 1 to 3 millimeters in size, you don't want the patient to move. In addition, let me take this. In addition, sorry, hold on, I'm pulling up the image. In addition, your navigation has to be spot on in order to use it. And so you can't have your head moving around. Can you guys see my screen? Josh, you there?
All good.
All right, so we're gonna shift gears a little bit. I just wanted to make sure you guys saw that because I think it's important to get the point across about how delicate and how small that all is. But virtual spine conference. And so we do spine, we do brain. This is an 81-year-old gentleman who presented initially with severe pain radiating down the lateral thighs, his buttock, and then the posterolateral thighs, and then to the top of his foot, lateral ankle. And so, we did what we usually do. I think everyone's talked about this at this point with regards to conservative management for these patients. He did physical therapy without relief. We actually tried steroid injections with him and medications without relief. And so we finally got him an MRI, and it shows this. And so I'd love to be able to chat with you guys. I don't know why it's not popping up right now.
You should be able to click the chat while you're sharing screen.
Yeah, I thought so too, but it's not. Let me see where it is. Hold on. More. Do I have it now? Chat. All right, good. Now, can you guys see the chat too?
The chat doesn't show up for us. It just shows
Oh,
up.
All right, good. So anyway, what do you guys think of this MRI? So someone said prolapsed intervertebral disc. And so that's not wrong without a doubt. You guys can see there's a little bit of a disc herniation here. All right. But it's not a huge disc herniation. I'll tell you that, and this is the axial corresponding to that level. Yeah, so Tedrick just said stenosis. Stenosis is the right thing. And so we're going to stop and we're going to go through this image just real quick. But this is the lumbar spine. All right. We're looking at a sagittal MRI, a T2 weighted MRI. All right. And on the right side here, this is an axial T2 weighted MRI. And I'll tell you, I didn't have the cut line here, but the cut line is right through this level, just like that, right through the disc space. All right. And when you look at this image, these are bones. All right. And then in between them are the discs, okay? And you can see that these are actually nice healthy discs. This is what they look like when they're healthy. They've got an outer rim of black and they've got an inner whiter part. And that's the nucleus pulposus, right? I don't know if they've talked about disc anatomy yet, but that's kind of the soft, more jelly-like material inside the disc. And then the outer part is the more fibrous ligamentous part. And as we get older, discs degenerate, they dry out, and you can see they turn more black as these down here, and they collapse a little bit, they prolapse a little bit or bulge, okay? And then in addition, you end up developing what's called ligamentous hypertrophy. So basically to keep, as it shrinks down, if there's mobility there, the ligaments thicken and they strengthen in an effort to keep you still and stable, all right? This is obviously the spinal canal in the middle here. This is the spinal cord. It ends around L1 in something called the conus. And then these are the nerve roots coming down, okay? The cauda equina is what we call it. And so you see here, what's it called? Do you guys remember what it's called when a bone moves forward on another bone in the spine? People chatting. Herniation, no. Spondylolisthesis, yeah, Avinav's got it. Subluxation, yeah. So this is what we would call an L4 on 5 aneurysthesis. And these are graded based on how far they are. Less than 25% is a grade 1, 25 to 50% is a grade 2, 50 to 75% is a grade 3, and then a grade 4 is, above that. And then spondyloptosis is when the entire bone is in front of the other bone, all right, greater than 100% or 100% or more, all right? So aneurysthesis, the reason that's important is if you can think about it, this moves forward on this bone, and the nerve roots are still in the same anatomic position. And so this puts stretch on that nerve root that's coming out here, okay? And then this disc bulge also puts stress on that nerve root. And so when you look at the axial cut now, all right, which is, you gotta remember how to look at these. This is a patient laying on their back, you're looking through their feet, all right? Which means that this is the right side and this is the left side, all right? These are the paraspinal muscles here, okay? This is the spinous process in the middle. These are the facet joints, right? The joints that hold each individual vertebral body to the next one. This is the disc, all right? These are other muscles that you don't, the psoas muscle, basically, which is retroperitoneal. This is where the lumbar nerve plexus is for the most part. This is also that thing they sell nowadays. It's like a pointy stick that you can massage your psoas, they say. I don't know if I believe it. It seems painful. And this is what's called significant stenosis, like someone said earlier, okay? And I'm gonna show you why that's stenotic here. Hold on. This is what a normal axial shot would look like, all right? So here you can see this is the thecal sac, decompressed. You can actually make out little dots inside of it. And those are all the nerve roots of the cauda equina. The foramen are wide open, all right? So the nerves can leave out the foramen. Now look at that and look at this, all right? In this one, all of those nerve roots are clumped into this tiny little space right here, all right? The foramen have disc material in them as well, all right? And then what you can't really tell here is there's significant ligamentous hypertrophy at this level. And so we know that we're ready for surgery now, right? We failed conservative management. And so the question is, what kind of surgery do we do here? So someone said, would you do an MIS TLIF or an anterior lumbar discectomy infusion? So great options, all right? But what's the question? So decompression. So when you think about spine, there's only like two things that we really do, all right? So decompression is one of them. So we have to decompress the nerve roots, right? We can't change the disease process. We're not changing degenerative spine disease in an 80-year-old, right? If there's a cure for that, whoever develops the cure for that is gonna make a lot of money for the rest of their life. Probably has, something to do with genes, and it's a whole different ballgame. But with spine surgery, we can do decompressions and we can do what? Fusion, someone said already. Great. And then we always have to think about front or back, right? And that's kind of how you have to target your approach. And I'll let Dr. Baum and Dr. Levine, Dr. Langer get into things about deformity and balance. Those are huge concepts in spine right now as we learn more and more about it. It's basically trying to figure out how to build a house or how to build a structure that's going to be stable. And in addition, it's going to treat people's pain. But in this guy, the basic consideration is, do we just decompress him, or do we do a decompression and a fusion? Do we just fuse him? So if we just fuse him, we're not taking care of the compression. So we're obviously going to decompress him. Now, what are the indications for a fusion? Why do you fuse someone? Instability. Yeah, exactly. So what is instability? This is a key concept here. Spine cannot support itself. I'll take that. How does it manifest, though? It's a clinical definition, to be honest with you. So a pars fracture would cause instability. Bones aren't able to stay in place. That's true. So that's visible instability. So that's basically, if you get an x-ray with someone bending and extending, the bones move, okay? Not really just degeneration. Unstable posture is true. So what it actually is it's back pain, axial back pain with normal physiologic movement. All right, so that means standing up, you get bad axial back pain as the bones sublux. All right, going upstairs, you get really bad pain. And then it's backed up, it's supported by imaging findings. So this guy has a grade 1 anterolisthesis, but when you stand him up, and I don't have the x-rays here, but when you stand him up and you bend and extend his back, it doesn't really move. And so there is likely some mild instability here, but he doesn't really have a significant axial back pain component. He really has ridiculous pain down his legs. And he's also 80, I think 81 or 83 years old or something like that. So there's a few different reasons to not pursue a fusion in a guy like this. Now, other things that you have to worry about is obviously, you know, lumbar lordosis. You have to take into consideration how many levels you have to do, and then front and back, what you can do. So coming from the front in this guy is not a particularly morbid surgery, but it's more morbid than just doing a simple decompression from the back. And there's pretty good data out there that says that in this situation with a stable spine and even a grade 1 aneurysthesis, a decompression is reasonable and has a durable response. What you don't want to do here is destabilize this guy and give him a worse problem than he already has. So I'm going to pull up a video. Oh, wait, let me find it. Hold on one second, guys. I'm flying by the seat of my pants here. Other ways to prevent this: yoga, vegetables. So like I said before, there's probably definitely a genetic component to degenerative spine disease. What that is, I don't think anyone really knows just yet. People are obviously very interested in it because, like I said, if you could fix it, it's a big deal. Weight loss is huge, all right? Strengthening your core is huge. Mobility, there's no one who's going to tell you that yoga and vegetables is bad for you, right? Those things are all good for you. And so I will tell you this, things that make it worse are things like diabetes, smoking cigarettes, nicotine. All right, wait, can you guys still see my screen here?
Yep.
Yeah, good. All right, so this is gonna be a little ad hoc. I'm gonna kind of talk our way through it, but this is, so what we chose to do was a minimally invasive lumbar laminectomy. And so what that means is that basically we localize the L4-5 interspace. We make a small tube. It's 22 the tube is 20 millimeters, so the incision is about 25 millimeters. So again, 1-inch incision just off the midline. I chose to come down on this guy from the left side because I'm a right-handed surgeon. It's just easier. Yes, you do use a C-arm, which is an X-ray basically in the operating room. And you make a 1-inch incision. You place a small wire down onto the spine, and then you use tubular dilators that, again, dilate to about 20 millimeters. So at 20 millimeters, if you think about it, it's probably the size of a quarter, maybe a little bit bigger than a quarter. And what these do, minimally invasive, is they actually, rather than burn and cut the muscle, they separate it. And so the muscle actually spreads around it, which means that it'll actually come back at the end. So it's really minimally invasive. There's no muscle takedown. And then when you basically dock right on the spine itself, on the bone, you do the whole surgery through this small tube. And so that's what we're going to watch here. And so this is kind of the initial localization. And I'm just going to let this play. I'll kind of talk through it fast forward as we go through. I'm watching, so if you guys have questions, we'll keep going. And so you start with a bovie, and you basically need to find bone. You need to find the bone of the spine. And so on this guy, we're actually on the left side. So remember, the head is going to be up here, and the feet are going to be down here. All right. And so there's basically always this small plug of muscle that needs to be removed, and you use Bovie cautery for that. And then let me find, that's that plug of muscle, and you can start seeing the nice white of bone deep to that. All right, I'm going to fast forward to the good stuff. So this little muscle is going to get taken out, and here's some bone here, right? As we enter. So what the anatomy here is a little bit tough, and it takes a little bit of getting used to. And so what you see is this is actually the spinous process, and this is the lamina, which means that you're also going to have here the facet joints, okay, based on the anatomy of this. I don't have a spine model in here to show you guys, but underneath the lamina right here about is going to be the inner space, okay? That's going to be the interlaminar space. And what that means is that's where you would get a lumbar puncture, basically. There's a space between the bones where the ligamentum flavum is going to extend between it, some other soft tissue. Now, a laminectomy means that we're going to drill away the bone over the ligament, and then for the decompression, we're going to remove the ligament, which is the primary issue. We don't have to do a discectomy here because the disc is so broad that all you really have to do is take the stuff off the back. How much does age affect the window for surgery to be done? It does, especially with comorbidities. And so we care about that a lot, which is, again, why we're doing a minimally invasive procedure to try to, this guy went home the next morning. Some people go home the same day if they're younger. I use an M8, Cedric. Discoloration of what? The bone is just charred at this point. The muscle looks okay. A lot of this is also degenerative changes. So it's not just the disc that degenerate, but actually the joints become hypertrophied as well. And there's a lot of kind of just fibrous changes that occur there. So anyway, this is kind of where we're getting to here. Here, we'll get that out of there. So again, so we've got spinous process, we've got lamina, and we've got the medial portion of the joint over here, and then interspinous, interlaminar space, okay? No, the black tissue is cauterized tissue again. Wait, sorry. So let's go to the next video and see where we're at. So here we're still kind of just shrinking back soft tissue. And now I'm using a curette to define the edges of the bone. So the spinous process and the lamina here. All right. Sorry, the tube's in the way here. Let's keep moving here. A little more soft tissue. You know, take the time with the exposure. We always say, go slow to go fast later. So if you can see everything perfectly, it's going to make your life a lot easier. It's going to make your approach better. And so really taking time. One thing I like to do, what you just saw there with the Bovie, is I'm looking at the pars. Remember someone mentioned a pars fracture before? The pars interarticularis is exactly what it says. It's a bridge between the two joints, basically. And so the reason it's important to identify is when you're drilling, you don't want to drill through the pars because you can actually create a pars fracture. And if you think about it, you break the bridge between the two joints, now you've created instability. So it's really important to me anyway, the way I do these, that I like to identify how much space I have. Are you taking images before and after as you go along? This is just a live video. This is actually the entire surgery just recorded. I don't use navigation for this. I use X-ray. We're in the lumbar spine, Anika. How does cauterizing the bone help you? Cauterizing the bone is not important. It's subperiosteal dissection of the muscle. So you basically have to get the muscle out of the way so that you can see the bone. So let's see where we're at. So again, just using cautery to define everything. So this is the medial portion of the inferior articulating facet of L4. Okay, and I'm defining the edges with the Bovie, making sure I've got everything in order. And the next step will be to go to the next video. Entry point of this surgery is just in the small of the back, the lumbar spine at the above the L4-5 interspace. And again, you use that with fluoro. And then the entry point of what we're going to do with the drill is the spinal laminar junction. So the spinous process is here, the lamina is here. This curve, this gentle curve right here, is the spinal laminar junction. And that's where we'll create something called a laminotomy, which is a hole in the bone, basically. So hold on, let's correct the imaging a little bit here. So operating through a tube, as you can see, this is the metal of the tube. We're in a 20 millimeter tube here. Some people do this through a 16. I typically use an 18. This is a 20. And so you want to make sure you're looking straight down the tube. And then I like to look down my suction when I'm going to drill. So you're going to see me move the scope a little bit here as the drill comes in. Again, this is joint over here. Here comes the drill. This is the spinal laminar junction, and you'll see I find the soft tissue, and I'm going to use the AM8 and drill start the laminotomy here. And so the key about the AM8 that's really nice is that the cutting edge is on the side. So you can actually drill on top of soft tissue as long as you're perpendicular to it and it won't cut through it. And so you can see that's the ligamentum flavum starting to come into view. And I basically just, just hover just above it and drill all the bone as I go forward. And so Deepak is actually with me on this surgery. He's irrigating a little bit just to clear the dust. I'm using my suction intermittently so I can see what's going on. And you can see it doesn't really bleed that much. There are some places that bleed more as you get up towards the pedicle, but for the most part, it's fairly bloodless at this point. And you can see we drill the lamina basically. And so the important thing to understand here is right now, the way the tube is oriented, I'm looking across the spine. So if the lamina is shaped like this, with the spinous process going up, I'm looking down this way and right into the middle and down this extra corridor here. Variable, spine anatomy is not that variable, and you typically know based on the MRI and x-rays. Bones do start to fuse when you get older. Young people have harder bone, and it's easier to operate on young people. Their planes are easier to dissect. I will use a Kerrison punch. You'll see a lot of that. We do remove the bone. As you can see, we're irrigating it away. You can see some bleeding starting to come in. Really, that's from the thicker part of the bone here where there's going to be more marrow. Marrow is what bleeds. Cortical bone doesn't really bleed. Post-laminectomy syndrome, there's different ways. It's a real problem. You don't get it in every case. It's more just some people get persistent pain. And it really is, it depends on what the cause of it is. It's multifactorial. So pain control, and then sometimes stimulators, sometimes more surgery, sometimes a fusion. How big is the hole you're making? So it's the whole lamina that we're going to drill off here. And so the lamina is it's probably also about, 2.5 centimeters, maybe an 1.5 inches, 2 inches. I've never felt, I'll tell you a funny story about feeling queasy. No, this is not gory to me. This is beautiful. But when I first, so you guys are just watching me drill here. I'm going to leave it on and tell you a funny story. So when I first decided I wanted to do neurosurgery, I was rotating with a guy named Jeff Bruce at Columbia. And I was, doing what you guys are doing. I was interested. I was there. And he was removing staples on a 26-year-old who had had a brain tumor surgery. And I was probably 25 at the time, 26. And it totally freaked me out. And I just passed out cold. I dropped. I slammed my face on a wall. I ended up getting 7 stitches on my right eyelid. They had to stop seeing the patient and take me down to the ER, and it totally annihilated me. And I was probably a first-year med student at the time, and so I thought I was doomed. I thought I would never be able to get into neurosurgery. I thought it was done. And for whatever reason, I don't know if he forgot or whatever, but it's a funny story. He went into his secretary's office and he screamed, "The med student just fucking collapsed. Get him out." And so they had to bring me to the ER. But anyway, but it all worked out. And the truth is with surgery, you're actually, you're protected. It's not gory. Good surgery is not really a gory situation. It's clean and it's precise, and if you're doing it nice and you're trained well, it's going to be a nice same way every time. So you can see here, this is an important thing to look at. This is the lamina and this is the ligament. All right, and you can see ligamentum flavum is yellow. All right. Give me 1 second, guys. Hold on. I gotta take this quick call. Hold on 1 second. Never mind, I missed it. So what I do here is you actually drill the bone over the ligament as it's going to curve to the other side, and you want to continue to drill in that way. We're going to go to the next video. Yeah, patients are not feeling this actively. There are parts that are stimulating, in which case they get boluses of other anesthetics. When we don't drill bone and put it back in, we usually bite that bone and put it back in, and that's for fusion. And that's because bone fuses better with its own self. It's called autograft. So you can see just widening. This is again the laminotomy. Ipsilaterally, the contralateral side, makes it a laminectomy because all the bone is coming off. And we leave the ligament down because the ligament's actually thick, and especially in this guy, it's extremely thick. It's actually protecting the thecal sac, it's protecting all the nerve roots. So Dr. Khatri is doing a wonderful job irrigating for me. The target tissue here is to remove the flavum and decompress the nerve roots. All right, some more bone coming off. Let me get to the good stuff. We're sort of running out of time. No rehab for this patient. This patient went home the first day better. These patients, when you decompress these nerve roots, they wake up and immediately are able to tell you that they're better. It's actually a great thing. It's the, I don't fancy myself a spine surgeon, but I do a lot of it. But they do get better immediately. No, irrigation won't hurt anything. You can irrigate all you want. Someone asked if irrigation can hurt the spine. So at this point, I'm drilling a little bit more on the ipsilateral side here just to make space. And that's because we're gonna have to move the thecal sac around a little bit. And so you wanna be able to retract not against bone. I'm also making it easier to remove the ligament. So at this point, we've got our laminectomy almost completely done, and we're looking at ligamentum flavum and some thick and soft tissue here, right? And the goal is to get to where the ligamentum flavum attaches. So I'm gonna pause this for a sec, but basically, I'll let it go. Ligamentum flavum attaches about 2/3 up at the body above. So at L4, it'd be 2/3 underneath the vertebral, the lamina, sorry. And then it's about 1/3 of the body below. So at L5, it would be just the superior third. And so if you drill far enough up, you can detach where it attaches using what's called a curette, which is what I'm doing here. And we're gonna move the curette completely around the bone. And there's definitely more bone to remove here. But we're gonna try to elevate the ligamentum flavum in as much as one piece or, as much as we can. It'll end up being piecemeal, but was this surgery solo or did you have supervision? I am the supervision. Does detaching the ligament to stabilize the spine? Probably a little bit, but not significantly. This is a safe and routine surgery, so not enough. Drilling the joints also contributes to that. Cutting the interspinous ligaments does. Basically anything you do, but that's why, again, the tubular retractors are so nice because we don't have to cut and burn that much. Scar tissue can come back and can cause compression. Absolutely. Does the lamina grow back? Yes, but probably not in an 82-year-old. How often do you tend to observe a surgery before you first perform it? Residency for neurosurgery is 7 years. Spine surgery makes up 70% of neurosurgery. In residency, you do surgery Monday through Friday for 7 years, sometimes on weekends, sometimes overnight. You watch a lot of surgery. You take part in a lot of surgery, and every year you progressively get to do more and more in those surgeries as you advance through training. It is not an insignificant amount of time. It takes a long time. And then you go out on your own, and then you start honing your skills and what you like or what you didn't like, and pulling from all your different mentors and teachers and finding the ways that you thought were better that one guy did it versus the other way another guy did it. And you put that all together, and then you go out and you do it. And you learn from your mistakes, which is something we've talked about in this a lot. All right, I'm futzing around here. This surgery's taking forever. You chose your own rotation. So there's a lot of core rotations in medical school. Someone asked if you get to choose your rotations, and then you get elective time, or at least mine did. I went to Rutgers, or back then it was Robert Wood, now it's Rutgers. Anyway, you can see this is extremely thick stuff. So what I'm doing here with the nerve root, now I've got the ligament up, I'm using this nerve hook to actually find the thecal sac. So there's a little bit of a difference in the tissue types here. I don't know if you guys can see it. So this is ligaments this way. This is a vein actually that popped into view. And then there's some epidural fat, which sits under the ligament. And that's a different color yellow. It's kind of pooching out a little bit right in the middle here. And I'm using the nerve hook to find the thecal sac between all this. And it'll start coming into view. I think I've showed you guys before, or I've told you guys before, and it's true. If you think you see dura, it's not dura. That what we just saw was dura. You always know when you see dura. Right there, you see that? It's peeking through, it's gray. But this is all this thickened hypertrophied ligament and scar tissue that this guy's developed over years. And so this is what's actually grown to the point that it's compressing his nerves and his nerve roots that and causing him his pain. After resin fellowship, do you find a mentor? If you're lucky, you do. There's always something to learn. And I'm telling you, watching people like the other important thing is finding people like Dave Langer, like John Bookvar. They trained in different ways, and we did surgery different. I mean, as early as 10 years ago. I mean, if you've been in practice even longer than that, 20 years ago, you've seen surgery really evolve. But it's nice to have that skill set. So Dave Langer has a skill set of cases that I will never see because we don't do them anymore. But in situations, rare situations where you need to actually use that approach or use that anatomy or use that experience, it comes in very in handy to have that guy around. How do you support yourself financially through residency? Residency pays a salary, and it's okay. New York residencies are okay. I found a girlfriend who paid for me a lot. Just kidding. If she's watching, which I know she's now my wife, by the way. So anyway, so now we're using a Kerrison punch to remove the ligament here. All right. And you can see that you can actually see, I don't know if you guys can appreciate this, the thecal sac is filling up the space where all that ligament was, right? And that's because it's expanding as we remove this. How was the board examination for neurosurgery? The written boards are easy. There's an oral boards that you need to log 125 consecutive cases. Then they review it, and then you go in front of a panel of examiners and you have to explain not only your cases, but cases they present to you. Why did you choose neurosurgery? I've always loved neurosurgery. I did actually look at everything though. For a minute, I thought I would do a trauma surgery. Thought I would be a trauma surgeon. For a minute, I thought I would be a cardiothoracic surgeon. When I first went to med school, I wanted to do neurosurgery, and then I really wanted to rule out other things. So I did rotations in everything. I spent a lot of time thinking about it. And the neurosurgery ultimately is incredible, right? Look, I'm operating on a back here. I just showed you me operating in the center of someone's brain. We operate on peripheral nerves. We operate everywhere. What's one characteristic you see neurosurgeons have in common? Attention to detail. And then, a somewhat rigid nature in terms of how we do things. Does anyone fail the board examination? Yes. Was there ever a time when you questioned if medicine surgery was right for you? Yeah, in college when I abandoned the whole thing to go play music for a long time, I definitely thought about it. But passions are passions. I always kept tabs on it. It came back and it was valuable. So, all right, so let's get back to the surgery for a second. You see the thecal sac expanded. All right, now we see the overhang of the contralateral lamina over here. You still see ligament around, right? So this is just extremely tough ligament. And so these are called Kerrisons. They're little toothed instruments. And what we do is we go in sideways and we turn it 90 degrees so that we only grab the ligament. You don't want to grab the thecal sac because you'll end up with a CSF leak here. So I'm going to fast forward a little bit because I want to show you guys what this looks like when it's decompressed. I think maybe this video's got it. So this is me aiming in the gutters here. That's actually the nerve root exiting. So I'm making sure that the nerve root's completely free at this point. The sac is the thecal sac. That's the dura with the CSF inside of it and the nerve. Maybe this video is not the best. Hold on. All right, up here, now I'm at the superior lateral quadrant here. We're just making sure all the ligament, you can see there's more stuff coming out. Just, you're here, you have someone anesthetized on the table. You're looking at their spinal nerves, their dura. You don't want to leave anything behind that you could have avoided. So you take that extra minute, you go through everything, a few times and make sure you're happy with the decompression. How long is the time from entrance to the decompression? It's different. It depends on the anatomy for the most part, but I would say you start decompressing, you start drilling within, 15 to 20 minutes. Someone asked, now that step one is something, what can you do to be competitive for a neurosurgery residency? I don't know the answer to that. It's a big matter of debate right now in neurosurgery. And I don't know if anyone has an answer. I think the thing to do is things that you guys are doing, which is show interest in it, get in touch with people, explain why you're interested. You want to go above and beyond and shine bright like a diamond. Am I allowed to say that? All right, wait, hold on. I'm gonna get to the next one because this is just boring. Watch me. Copyright strike pending. Yeah, I know this is gonna get. Actually, if you use less than a certain amount of time of a song, you don't need to license it. I know that because my wife is a DJ. So this is actually FlowSeal. I think we're back, and this is the end of the case. Hold on, let me go back one video so you guys can see. Here we go. So we're getting, this is FlowSeal. So these are little bits of gel foam soaked in thrombin that we spray, and they'll actually stick to anything bleeding and actually stop the bleeding. And then we irrigate that away. Whatever comes loosely, you're allowed to just float away. Whatever sticks means it's stopping bleeding. But you can see how, like, look what's in this hole now. This is all fecal sac, right? This was all compressed. It's completely filled that. Does the gel foam be removed? So you just irrigate what comes out, the rest can stay. Throughout the entire surgery, you only see through this 20-millimeter tube, that's right. Which tissue is striated? So the dura is running lengthwise here, from anterior, from rostral to caudal, or from the head to the tail, basically. Muscle is obviously striated because it's muscle. So anyway, here's the final wash. So the ligament is thickened and it's pushing the fecal sac against the ventral disc herniation. Look at how beautiful that looks. Totally clean. Nice poochy dura, everything's good. And then the bone stops the ligament from being able to expand posteriorly, right? So you take the bone off, you take the ligament off, this stuff all expands, it inflates with CSF and fluid, and his pain goes away. It's like miraculous. So incision closure. So what you do, this is actually a little key part too. That's a piece of gel foam we leave over the durotomy, so that when we come back, we don't ever, if we ever come back, we don't cut right down into the dura. There's a layer of protective tissue there. All right, let me go to the last video, only because it shows you, I think, to some degree, when we pull the tube out. Yeah, so this is final hemostasis. We use Bovie. We're looking down the tube. We're pulling everything out, making sure we stop any other bleeding. And you can see how those muscles are already starting to come back into place. And that's it. Tube comes out. That's the small incision. All right. You can see down the little hole. So it's a 1-inch incision, 2.5 centimeters. Stop all bleeding there. And so what you do now is you have to close the fascia, because you can actually get a muscle herniation. And you do that with a very strong absorbable stitch. And then you close the skin with absorbable stitches underneath the skin. And then there's one last absorbable stitch that approximates the edges, so it looks perfect at the end. And I don't think he does this under a microscope. I didn't close this. I think Dr. Khatri did. And so I'm pretty sure that's done off camera, but that's it. That's the whole incision. You saw actually, you know what, this might have been a 2-level, so this is a bigger incision. This is because we went down and we did the level below too, but the standard case is a 1-inch incision. Yeah, so that's actually, this is the K-wire. We're gonna redock the tube for the next level. So we did it at 1 level, now we're gonna do the 2nd level. But you guys don't have to watch that, same thing. So is there ever a situation where non-absorbable sutures are used under the skin? We use silks occasionally when we need stuff to stay. pretty infrequent. There's a higher risk of infection when you leave something that doesn't absorb, but everything's a risk of infection. So